Welcome to the deep dive. Today, we're plunging into some pretty high-yield revision notes, specifically focusing on a pediatric condition. Now, it's much rarer these days, but it really demands your absolute attention
It really does.
because of how quickly things can, well, go wrong. Our mission today is to pull out the essential, the absolute need-to-know facts about acute epiglottitis.
Yeah, distilling these notes into something you can grasp fast and remember effectively.
Exactly. Think of it as cutting straight to the chase,
Yeah.
getting that core info without getting lost in, the extra details.
It's a classic condition where rapid recognition literally saves lives. And these notes, the source material we're looking at, they do a great job highlighting those crucial points.
Perfect for breaking down into a targeted briefing for you, the listener. So let's get right into it.
Let's do it.
Okay, diving into these notes. What's the fundamental definition? What exactly is acute epiglottitis?
So at its heart, it's a severe bacterial infection. And the critical thing is the consequence of that infection.
Which is
Rapid inflammation and swelling of the epiglottis.
right, the epiglottis. That's that little flap of cartilage, sits right at the base of the tongue, sort of guards the windpipe.
Precisely. It's basically the lid for your airway.
And when that lid swells up dramatically,
It can block the air getting into the lungs. That's where the life-threatening danger comes from. It's an airway emergency.
and the notes make a really key point right up front, don't they? About how things have changed.
Oh, absolutely vital point. Historically, the main culprit was Haemophilus influenza type B, Heb.
Pay pray.
But thanks to widespread Heb vaccination programs,
Wow.
well, the incidence of epiglottitis caused by Heb has just plummeted.
Wow.
It's a huge public health success story, and it directly impacts what you'd see clinically today.
So vaccination didn't just cut down cases, it kind of shifted the whole landscape of the disease itself. That's a really powerful takeaway from these notes, actually.
It really is.
So, okay, Heb was the big one. Are there other causes mentioned under etiology?
Yeah, the notes do list other bacterial pathogens that can cause it, and less commonly, sometimes viral infections are implicated too.
And that naturally leads us to risk factors then. If vaccination was such a game changer, I'm guessing the biggest risk factor relates back to that.
You got it. The primary risk factor highlighted is being unvaccinated, or, incompletely vaccinated against Heb.
Makes sense.
Other factors mentioned include things like exposure to tobacco smoke and maybe a history of recurrent upper respiratory infections, things that might predispose someone.
Okay, so we know it's an infection causing swelling, but how exactly does that turn into such a sudden, dangerous emergency? What's the pathophysiology the notes describe?
Well, it's the speed. That's the crucial bit. The bacterial infection triggers a very, very rapid inflammatory response, specifically in the epiglottis.
Rapid. There's that word again.
Exactly. And that inflammation leads to swift, significant swelling of the epiglottis and the tissues around it.
And the airway there is pretty narrow to begin with.
Right. So even moderate swelling can quickly cause partial or even complete obstruction. This leads straight to rapid onset respiratory distress, difficulty breathing. It's not a slow burn, it's like a switch flipping.
That really underscores the urgency. Okay, moving on to epidemiology. Who are we actually seeing affected now, given that Heb is largely controlled by vaccines?
Well, firstly, the notes confirm it's now rare. In places like the UK, because of that successful routine Heb immunization.
So if you do see it,
It's most likely in someone who hasn't had the full course of Heb vaccination.
and age-wise, it used to be mainly young kids, didn't it?
Yes, before the vaccine, commonly children aged, say, 2 to 5 years old. And they're still the most susceptible unvaccinated group.
What?
But significantly, the notes point out adults get it too, often in their 40s and 50s, and it seems to be a bit more common in men.
Interesting. Any reason why in adults?
Often, underlying medical conditions that affect immunity can be a factor in adult cases.
Right. Okay, now here's where it gets, well, really interesting and frankly critical for anyone needing to spot this. The clinical features, the red flags. The notes really hammer home that rapid onset aspect here, don't they?
They absolutely do. This isn't something that develops slowly over days. Symptoms appear and they worsen quickly, often within just hours.
So what signs should jump out at you? Give us the list from the notes.
Okay, so high fever is typical. A severe sore throat often seems much worse than what you might see just looking in the mouth.
Okay.
Difficulty swallowing dysphagia, that's a major symptom. And related to that, a really telling sign, especially you see this in children, is drooling.
Drooling. Why?
They just can't swallow their own saliva. It's either too painful or the airway is too compromised. They just sort of let it dribble out.
That's a strong visual. And the voice change. The notes have a memorable description for that, too.
Yes, the voice becomes muffled. Sometimes they describe it as a hot potato voice.
Hot potato voice.
Yeah, like they're trying to talk with something really hot in their mouth, you know? Makes it hard to articulate clearly. Sounds thick, muffled.
Got it. And obviously signs of breathing difficulty.
Yes, respiratory distress, definitely. Struggling to breathe, and you might hear stridor.
Stridor, just to clarify for everyone listening, that's the high-pitched, often quite harsh sound when someone breathes in, right?
Exactly. It's caused by air trying to squeeze past that blockage high up in the airway. It's a critical sign here.
And there's a posture associated with this, too, especially in children.
There is. Kids, trying instinctively to maximize their airway, will often sit or stand leaning forward, sometimes with their hands on their knees. It's called the tripod position.
Tripod position.
Yeah. It's a visual cue that should immediately set off alarm bells about airway compromise.
Okay, so some of these signs, sore throat, fever, maybe stridor, they could overlap with other things like croup, maybe. The notes include a list of differentials. Why is that list important?
It's vital because you need to consider other conditions that might present similarly, but crucially need completely different management.
What's on the list?
The notes mention croup, obviously,
Right.
also peritonsillar abscess, retropharyngeal abscess, severe laryngotracheobronchitis, pharyngitis, laryngitis, and even an inhaled foreign body.
So quite a few possibilities.
Yes, but while they might share some symptoms, that rapid onset, the specific combination of high fever, severe sore throat, the drooling, the muffled voice, in someone who looks really unwell, that should push epiglottitis much, much higher on your suspicion list.
Compared to, say, typical croup.
Right, which often has that characteristic barking cough and tends to develop a bit more slowly. The pattern is different.
Got it. The differential helps you think broadly, but prioritize based on that specific pattern. Now, this leads us to investigations. How do we actually confirm this, and what are the absolute don'ts based on these revision notes?
Okay, this is possibly the single most critical piece of practical information regarding investigation.
Which is?
Do not attempt a throat examination with a tongue depressor. The notes are crystal clear on this.
Why not?
It carries a really high risk of triggering sudden, complete airway obstruction in a patient whose airway is already incredibly precarious. It's just too dangerous.
That's a huge, potentially life-saving memory point right there.
Oh.
Avoid the tongue depressor.
Absolutely.
So if you can't just look with a depressor, how is the diagnosis confirmed visually?
Well, the gold standard for actually seeing the epiglottis is laryngoscopy, using a scope to look directly at it.
Okay.
But, and this is non-negotiable, this must be done in a controlled setting, ideally an operating room.
Why there specifically?
Because you need senior staff present who are fully prepared for emergency airway management. That means ready to intubate or even perform a tracheostomy immediately if looking actually precipitates obstruction. Safety is absolutely paramount.
Right. Controlled environment, ready for anything. What if that immediate controlled laryngoscopy just isn't feasible, or maybe too risky initially?
The notes mention a lateral neck x-ray as a potentially useful alternative, but it has to be done carefully.
How so?
Ideally, with the patient sitting up, without causing them extra distress. And what you're looking for on that x-ray is the thumbprint sign.
The thumbprint sign, can you describe what that actually looks like or represents?
Yeah, so imagine looking at the x-ray image, the side view of the neck. You see the dark space, which is the airway. The swollen, inflamed epiglottis can look like a sort of big, rounded thumb pressing into that airway space.
Oh.
Right where it narrows. It's a visual clue that the epiglottis is significantly thickened and swollen. Gives you a strong indication.
That's a much clearer picture, thank you. Are other tests mentioned in the notes? Any blood tests or swabs?
Yes, throat swabs can be taken to identify the specific pathogen, the bacteria causing it, but only after the airway is secured and the patient is stable, definitely not before.
Airway first, swabs later. Got it.
Right, and blood cultures are appropriate if the patient seems systemically unwell, septic perhaps, and things like CT or MRI scans might be considered, but usually only if there's suspicion of an abscess having formed, like in the epiglottis itself or nearby tissues.
So it sounds like while those tests help confirm or find the specific cause later, the initial suspicion and the crucial immediate steps, They're based purely on those clinical signs we talked about.
Exactly. The diagnosis is primarily clinical. You recognize the pattern: rapid onset, fever, bad sore throat, drooling, muffled voice, maybe that tripod position, stridor. You act on that.
Then you manage the airway safely and confirm things with appropriate lower-risk investigations like that carefully obtained X-ray or the controlled laryngoscopy later.
Precisely.
Okay, so once that suspicion is high, or perhaps it's confirmed, what does the management section of the notes say is the immediate plan? What do you do?
Right, well, first step,
Yeah.
immediate hospitalization. This is an emergency. It requires expert care, usually in a hospital setting.
And the absolute top priority, no question.
Airway management and stabilization. That's the cornerstone. Everything hinges on that.
And what might that involve?
Depending on how severe things are, it might mean expert intubation. So, placing a breathing tube directly into the windpipe, bypassing the swollen area, or in rare, very difficult cases, maybe creating a surgical airway via tracheostomy. The goal is just to secure that airway.
What about treating the actual infection?
Intravenous antibiotics started immediately, targeting the typical bacteria involved.
Makes sense. Anything else?
The notes also suggest considering steroids. 4V steroids might help reduce the inflammation around the airway, though this is generally secondary to actually securing the airway itself. Airway first, then maybe steroids.
And there was a note about protecting others, contacts.
Yes, the notes mention that if the cause is confirmed as Haib, which is less common now, but still possible, then prophylactic antibiotics, specifically rifampicin, can be given to close household contacts.
Especially unvaccinated children in the house.
Exactly, to prevent any secondary cases popping up.
It sounds like these patients need a really high level of monitoring and care throughout.
Oh, absolutely. Admission to an intensive care unit, or at least a high dependency unit, is pretty standard practice. You need continuous monitoring of their airway and their respiratory status. You can't let your guard down.
Okay, finally, let's look at prognosis and complications. What's the likely outcome if it's caught and managed quickly? And what are the risks if there's a delay?
Well, the good news, and the notes highlight this, is that with prompt recognition and the right medical intervention, the prognosis is generally good.
That's reassuring.
Yeah.
And the danger. What happens if there is a delay?
The danger lies entirely in delay. If treatment isn't rapid, that swelling can lead to complete airway obstruction and respiratory failure, which unfortunately can be fatal.
So swift action to secure the airway is really what prevents those severe outcomes.
Absolutely. That's the whole game.
Do the notes give any sort of figures on recovery or how often complications happen?
They mention that the majority of patients do recover fully with early diagnosis and management. They also note that intubation, needing that breathing tube, is required in only about 15% of cases overall.
Oh, really? So not always needed.
Suggests that very early intervention can sometimes avoid needing it, although obviously readiness to intubate is absolutely key. You have to be prepared.
And outcomes between adults and children.
The notes suggest outcomes are often a bit better for adults than children, perhaps just due to adults having a larger airway diameter to begin with, a bit more reserve.
What are the specific complications listed beyond the big ones like airway obstruction and respiratory failure?
Right. The notes also list pneumonia as a possibility, sepsis, so the infection spreading systemically, and just local spread of the infection to nearby tissues.
Okay. And any rare issues mentioned?
Yeah, rarer complications include abscess formation. Actually, within the epiglottis itself, that occurs in maybe about 25% of the cases that do get complicated.
A quarter of complicated cases. Wow.
Yeah. And then very rare things can include meningitis, if the infection spreads that far. Pneumothorax, which is a collapsed lung, and pneumomediastinitis air tracking into the chest cavity around the heart and lungs. Very rare, though.
That's quite a concerning list, but it sounds like it's largely mitigated by that crucial prompt action we keep coming back to.
Precisely. It brings us full circle, doesn't it? Knowing these key signs, acting fast, acting safely, that's everything with epiglottitis.
Well, that was a really focused deep dive into those revision notes on acute epiglottitis. I think we've pulled out the absolute must-know information.
Hopefully.
You know, the dramatic impact of the Haemophilus vaccine, making it rare, but definitely not extinct. The critical feature being that rapid onset. The key clinical red flags. The drooling, the hot potato voice, that tripod position, the absolute no-no of using a tongue depressor for examination.
Crucial point.
The necessity of controlled airway management for definitive visualization, and that clear management pathway.
Yeah.
Immediate airway stabilization, antibiotics.
Yeah, hopefully this distillation gives you, the listener, a really high-yield package of information, ready for recall when you might need it.
And it also serves as a powerful reminder, doesn't it, based on the epidemiology, just how profoundly public health interventions like vaccination can change the landscape.
Absolutely. Seeing a condition like this transform from what was a relatively common, often deadly threat into a rare event, it really underscores the success and the ongoing importance of these vaccination programs. It's a direct link between public health and what we see, or thankfully don't see as much, in clinical practice.
That's a really vital perspective to end on. Thank you for joining us for this deep dive into the source material today.
Always happy to share the insights. It's important stuff.
Keep exploring, keep learning, and we'll catch you on the next deep dive.